Good afternoon. It's 1:30, and unfortunately for you, the technical difficulties were solved, so you're going to have to sit through this. My name is Miguel Cobas from the University of Miami. I have the pleasure of presenting this talk with Roshni Sridharan and Bridget Flynn from the Cleveland Clinic and the University of Kansas, respectively. Anesthesiologists, intensivists, great colleagues, and great friends. So it's going to be, hopefully, a good panel. Feel free to interrupt me when I finish. I don't have any financial relationships or commercial support to disclose. So let's get going. We're going to talk about papers that we thought that were interesting for the world of critical care and anesthesia. So let's see the first one that we have. You probably have heard about it. It's the FLUID trial. The FLUID trial is a crossover trial of hospital-wide lactated Rangers versus normal saline. What they did was a very interesting design, and I'm going to point it here. They did lactated Rangers. They did 7 hospitals. Lactated Rangers for about 4 weeks, for 12 weeks in one hospital. Everybody in that hospital got lactated Rangers. Then they washed out a period of 2 weeks, and the hospital that got lactated Rangers used normal saline and vice versa. So they got a lot of patients. The good thing is that it's the biggest fluid trial today because we're always wondering what fluid is better. It's the most conspicuous thing that we do in medicine, not only in critical care. What fluid is better? So it's the biggest fluid trial. It captured all fluids before the ICU, which is good. And the adherence to the protocol was pretty good. What was the thing that were not that great? The trial was interrupted because of COVID. So only 50% of patients ended up in the ICU, which is kind of the normal ratio, and only 1% difference. So maybe the study was a little bit underpowered. And if you look at here, the composite of death or readmission to the hospital was about the same. 20.3% in the LR solution, and normal saline was 24%, 21.4%. So the conclusion of the trial is that a hospital-wide policy to administer LR rather than normal saline did not result in a significant lower incidence of death or readmission to the hospital within 90 days. For people who grew up around my time, normal saline was the devil, okay? It gives you acidosis, it gives you renal failure, it gives you all of those things. It probably still has a little bit of an effect on the hypernatremia and maybe a little bit of AKI, which they didn't look into this, but in general, normal saline, we can say it's not the devil as much as we thought it was. And if you look at a trial that was published about 2 years ago, that was published in New England Evidence, it showed that a prior meta-analysis of trial testing fluids in critically ill patients, and they looked at around 34,000 patients, found a non-significant trend toward a small mortality reduction with balanced solutions. In other words, a big meh, nothing here. So I think we can probably say that LR and normal saline are probably equivalent in most of critical care settings. Second study. This was a guideline study. Transfusion of fresh frozen plasma and platelets in critically ill adults. Interestingly enough, if you look at data looking for transfusion of RBCs, there's tons of studies. The data is really good, really robust. If you look at transfusion of FFP and platelets, it's very crappy. There's only one randomized trial and 15 observational studies. So it's very hard to make very strong arguments when you look at this. And the guidelines of CHEST, they listed conditional recommendations based on very low quality evidence. However, the overarching principle is that we should aim for a restricted transfusion strategy. And the conclusion of the trial is that, or the guideline, I'm sorry, is that given the known risk of blood products transfusion and the limited data regarding the benefits from platelet or FFP transfusion, most patients will benefit from avoiding transfusion of these blood products. And I put this here, these little boxes here, and say, if the patient doesn't have less than 10,000 patients and it's a low risk of bleeding patients, don't give it. If it's a high risk of bleeding, probably you should consider transfusion only between 30 and 50,000. And if the patient has active bleeding, then you should keep the platelets above 50,000. So, other conclusions of these guidelines. For procedures, you shouldn't routinely transfuse for lines, thoracentesis, paracentesis, bronchoscopy, or endoscopy. However, there is an exception. For lumbar punctures, the guideline says that you should aim to keep your platelets between 40 to 50 and an INR less than 1.5. And again, consider the platelets only with those numbers, which are the ones that you have down here. And they don't make any mention, which is important, because I'm sure we have all neurosurgical colleagues that say, if the patient has an intracranial bleed, platelets above 1,000. Neurosurgeons are great random number generators. I don't know where this number came about. Platelets above 100,000 on a TBI. However, this guideline did not address that. And it says, do not use prophylactic FFP in non-bleeding patients, and only use FFP for major bleeding, coagulopathy, massive transfusion, or specific factor deficiencies. So the problem with this trial, or these guidelines, it says that their overarching principle, we suggest against prophylactic transfusion for patients perceived as being high risk for bleeding in multiple clinical situations. But it also says, in patients with high risk of bleeding, or where the bleeding complication may be catastrophic, transfusion should be considered. So this is an inherent dichotomy on these two recommendations, because a major challenge in this recommendation is defining what is high risk of bleeding. There's no universally definition accepted of what is a high risk of bleeding. So what do we conclude after reading these guidelines? There is a major US specialty society that advises against most routine transfusions of FFP and platelets. The high quality evidence is absent, and clinicians in general over-transfuse plasma and platelets out of concern of major bleeding. The guideline supports clinicians to resist their own local practice patterns, training, habit, or even anxiety. However, most plasma and platelets transfusions are probably unnecessary, but there's no reliable way to tell in each individual case. So I'll give you that there. This next one, third trial, is a quirky one. And how many of us don't all of a sudden we get somebody in the OR or in the ICU and say, oh, the patient is 95. Oh, God. You know, it's like, why? What's going on? Why are we doing that? So this is a summary that looked at over 17,000 patients over 90 years old or over 100 years old, nonagenarians and centenarian patients that are admitted to the intensive care unit, and they look at the review of this. And interestingly enough, 80% of these patients over 90 years old had a 1-year survival of over 50%, 6 months of around 40, and 1 year about half, which is not bad when you consider the starting age that we're working with. 40% even were mechanically ventilated, which I thought there was a very large percentage. And the length of stay was around 5 days here, and the hospital length of stay was around 12 days. So the clinical implications and conclusions when we have patients that are 90 or over 100 years old is that age alone is not a contraindication for surgical procedures or even for admission to the ICU. Many of them will survive to discharge. They will assess frailty, comorbidities, and pre-admission function. It's good to offer on a limited trial basis. Like you can tell the family or their significant other, say, hey, we're going to use a trial of maybe 48, 72 hours, see how the patient does, and based on that, we're going to decide if we're going to take any step further or not. And we should anticipate that there will be cardiac and renal complications, possibly pressors, and prolonged rehab, obviously, in this patient population. So emergency surgery in a fit nonagenarian or centenarian with previously preserved function is reasonable to offer ICU care. And as long as we discuss expected complications and probable survival, there's going to be probable survivors to discharge. There's probably going to be in patients with severe multisystem failure in frail nonagenarians with high comorbidity load. I think it's reasonable to offer a discussion of goals of care and default to a time-limited trial to see how the patient does. And cardiac arrest with poor ROSC and high comorbidities, the outcomes are likely poor. We know that the outcomes are likely poor even on relatively healthy patients with cardiac arrest. So weight against baseline function and previously expressed wishes. So let's talk about another study. What is better, intraosseous or intravenous? So I'm going to bring you two studies in one. So the first one is called IOIV. This was I think it's a Finnish study. They look around almost 1,500 patients with around 70 years, 70% men. These patients had non-traumatic out-of-hospital cardiac arrest. Obviously, they needed vascular access, and that was not already in place. The vascular access, interestingly enough, was established successfully within 2 attempts in 92% of the patients in the intraosseous group. And 80% of the patients who needed IV. So intraosseous was relatively faster, or they got more patients with that. But if you look at the ROSC in this patient, intraosseous axis and intravenous axis was exactly the same, 30 and 29. And if you look at the survival at 30 days, it was only 12 and 10%, which actually talks about how poor the survival for out-of-hospital cardiac arrest is in general. The conclusion of the study is that among patients with out-of-hospital cardiac arrest, the percentage of those with sustained ROSC did not differ significantly between the two groups, the one assigned to intravenous or the one assigned to intraosseous. So the other trial that was, let's say, in sisterhood with this one is a randomized trial of drug route in out-of-hospital cardiac arrest. This is called the Paramedic 3 trial. It was performed in the UK, a little bit bigger, 6,000 adults, 68 years, and again, out-of-hospital cardiac arrest, they need an IV or IO. And interestingly enough, if you look, the time to drug administration is 24 minutes, which is relatively long. That's something to consider. But if you look at the survival at 30 days, 44.5 and 5.1, exactly the same. And if you look at favorable neurologic outcome, very low, 2.7 and 2.8, so basically the same. So the conclusion of this particular trial, Paramedic 3, is that among adults with out-of-hospital cardiac arrest requiring drug therapy, an intraosseous first strategy for vascular access did not result in a higher survival at 30 days than an intravenous first strategy. So what can we conclude after these two solid and robust trials of IO versus IV? Is IO is easy to learn and use if you have the equipment. It actually may be faster and may be able to get intravenous or reach the circulation a little bit more patients than the other ones. It's an attractive option during emergency, especially if you don't see the veins relatively quickly. In the Paramedic 3 trial, they had a lower rate of ROSC, so that's something to consider. However, in both trials, they say that they have the same amount of mortality and neurologic disability. So the important thing is how to get to the circulation. Is to get to the circulation, not how you get to the circulation. So the method for vascular access is probably not important, and intraosseous should still be a plan B. Next one, okay? This is a summary statement of cardiac arrest. It's the 2024 International Consensus on Cardiopulmonary Resuscitation. This is an international consensus, but a lot of these recommendations are then incorporated into the AHA algorithms or IHA recommendations. So let's go over the most important things here. We have to remember that this trial has very low quality body of evidence. There's very difficult to randomize or to get consent for patients in cardiac arrest to begin with. So the quality of evidence is not gonna be great. So thumbs up, adults with out-of-hospital cardiac arrest should be treated in a cardiac arrest center. What is a cardiac arrest center? The one that has a cath lab with a PCI capability of 24/7, mechanical ventilation, target temperature management, which has changed a little bit, as we all know, neurology consultants, and possibility of ECMO. And if you look at the plot, it favors the treatment in a cardiac arrest center. Okay, backboards. It's okay to use backboards only if they don't delay the initiation of CPR. Other than that, don't worry too much about having backboards. Audiovisual feedback devices can improve CPR quality. What are audiovisual feedback devices? We've probably heard it all the time. Press harder, you suck, you're doing fine. That type of thing, right? So those things, those annoying things, those audiovisual feedback can improve CPR quality, so pay attention to that. The temperature targets after cardiac arrest now are less than 35. It's okay. We have gone from 32, 35, 36, now less than 37.5 is okay, less than 37.5. The prevention of fever now can be switched from 36 to 72 hours, from 72 hours. Before it was a fixed 72 hours, now they're saying probably 36 to 72 is okay. And the targets for oxygen, entitled CO2, and BP are also relatively new. The SpO2 should be maintained between 94 and 98 with a PaO2 of 75 to 100, and entitled, basically a normal entitled, between 35 and 45 after ROSC. and mean arterial pressure between 60 to 65. They couldn't define if 60 was worse than 65 and things like that. So we're probably, with like most of the things, 60 or 65 is probably okay. This is a long slide. I'm not going to go into much detail on this, but the important thing is that routine seizure prophylaxis after cardiac arrest is weakly discouraged. We probably shouldn't be using it. And there's weak support for treating rhythmic and periodic EEG patterns on the ictal interictal spectrum. If you are really interested about knowing ictal interictal spectrum, please reach out to me after the talk, because we need to go through a lot of things, but those are the ictal interictal spectrum of the EEG. What else do they say? Thumbs up to pocket cards, thumbs up to visual reference guides, thumbs up to gamification of CPR training, so great for those who grew up in Minecraft. Thumbs up to the briefing after codes, so all of those things. Not really in either thumbs up or thumbs down. No decision regarding for or against eCPR, virtual or augmented CPR training, or ultra-portable ADs. I guess we'll have more information on that in the next iteration of these guidelines. And my last study, another guideline, corticosteroids for treating sepsis in children, because a critical care lecture cannot be a critical care lecture if we don't talk about steroids or sepsis. So, corticosteroids for treating sepsis in children and adults. Moderate certainty, corticosteroids probably reduce 28 and 90% a 90-day mortality. The benefit is clearest in those patients that are requiring vasopressors, may shorten the ICU and hospital length of stay, and that is a low certainty statement. The main harms, most likely, the patient is going to get hypernatremia and hyperglycemia with moderate certainty. Those are complications. There's no consistent increase in nosocomial infections, which is always a concern when we're using steroids. And the pediatric evidence is sparse, so caution on that. And so these are the final conclusions. It says, consider hydrocortisone 200 milligrams a day, bolus or infusion for refractory septic shock. Monitor the sodium, the glucose, and muscle weakness, especially if you're going to use muscle relaxants. And the typical duration should be between 5 or 7 days, and we should taper as the shock is resolving. And always in rounds, somebody's going to ask, shouldn't we use fludrocortisone instead of hydrocortisone? Now you can say, well, there's a guideline that says that there is some certain added benefit to using fludrocortisone, and they will probably not ask you another question. And with this, this is the end of my presentation. This is the QR code. There is a summary with, if you take it and you'll see it with all the other presenters, there's a summary that we have put together with all the studies that we're sharing, and that is my email. If you need to write or anything like that, I'll be more than happy to answer. Thank you very much.
Join up? Okay. Good afternoon, everyone. Thank you for this opportunity, and thank you for attending our session. So I'm going to continue. We have I'll be presenting another 6 studies. And the first one that I'll be presenting is, again, one of the key topics that no critical care talk can end without an ARDS study. So this one is, the first one is the inhaled sedation in ARDS. It's a CSER randomized controlled trial. So the background is, ARDS is common. We see it, very high mortality. One of the things that has not been looked at very closely is what sedation protocol is going to be helpful as far as outcomes go in patients with ARDS. Commonly, propofol is utilized. This study specifically is looking at inhaled sedation, or sevoflurane, in this particular case, and this is a randomized control study. And they've compared inhaled sevoflurane versus intravenous propofol for sedation in patients specifically with moderate to severe ARDS. It is multi-center. It was an open-label study. It was done in France. It was 37 ICUs that they had enrolled patients in. And specifically, the inclusion criteria for these patients was adults who had early, moderate to severe ARDS, where the expectation, they were ventilated for less than 24 hours, but the expectation is that they were going to be ventilated for a longer period of time. They were randomized 1-to-1 to sevoflurane or to propofol. And another key important factor in this, that all of these patients were deeply sedated as far as the sedation score goes, and all of them had cisatracurium that was utilized for less than 48 hours. They did do light sedation for their daily awakening, though. The primary endpoint that they were looking at was ventilator-free days through day 28, and some secondary outcomes, including mortality, which was 90-day survival, 7-day mortality, and ICU-free days. So some of the key results that they noted was specifically for their primary outcome when they were looking at ventilator-free days, there truly was no major difference between using sevoflurane for sedation versus propofol. But when they were looking at the secondary outcomes, specifically the 90-day survival, they did notice that patients who had sevoflurane as sedation, they did have lower survival. They had an increased 7-day mortality. They had lower ICU-free days. And they did tend to look at acute kidney injury. They don't have long-term outcomes that they look at. And one of the limitations of the study was that they didn't have an opportunity to look at long-term outcomes. But there was higher AKI in patients with sevoflurane. And the QR code is for all of our summaries together that you'll see. It's there in all of my slides. So the limitations of the study, of course, is open label. So then there's a concern there could be a bias. There's so many other therapies that we utilize, which are all controversial in ARDS, steroids and how much fluids we give and whatnot. So those aspects were not incorporated, and it's very difficult to incorporate, and so hence were not incorporated in the study. Uniformly, deep sedation was utilized, so we have to be careful if you're trying to extrapolate this data into institutions that are not using that kind of deep sedation. And there was quite a large number of COVID-19 patients in the cohort, over 50%. So again, there has to be caution when we're interpreting this data if you're looking for another subset of patients and not necessarily COVID-19 patients. And again, long-term outcomes were not looked at. So as far as generalizability and what do we... It looks like it's taking my hand motions. It did. So as far as generalizability goes, so it is a large study. They did have 75 ICUs, which are included. So of course, it is good in that aspect. And the control group's mortality did match the other ARDS studies which are done. So as far as robustness of the data, it seems to be pretty good. So the findings are mostly applicable to ICUs, which are using deep and early sedation with cisatracurium. We have to be cautious as far as interpreting or extrapolating this data to other ICUs in different settings, which are using lighter sedation strategies, or if it's non-COVID ARDS. So the next study that I'm going to talk about, it is a systematic review and a meta-analysis. This is looking at delirium and acetylcholinesterase inhibitors as prophylaxis or as treatment. So delirium is common in hospitalized patients, especially in older surgical ICU patients, and we really don't have good prophylactic strategies, and even the therapeutic strategies, there's very limited data on antipsychotics. So looking at the cholinergic hypothesis, the thought was to see, do anticholinesterase inhibitors, do they play a role in either being a prophylactic agent or a therapeutic agent in these patients who are older surgical patients in an ICU? So the objective of the study was to look at this particular agent. And they looked at the systematic review and meta-analysis following PRISMA. And they looked at all the RCTs, which were looking at acetylcholinesterase inhibitors as either as prophylaxis or treatment in patients with delirium. So their primary outcome that they were looking at was delirium occurrence. There were some secondary outcomes they were looking at, including how long the duration of the delirium, how severe was the delirium, and the hospital length of stay and whatnot. They did see that in patients who did get acetylcholinesterase inhibitors, there was a 32% lesser risk of occurrence of delirium, but not in any of the other categories that they were looking at, as far as change in delirium duration, overall change in their severity, or in the hospital length of stay. They couldn't see anything, or they didn't find anything significant through this analysis. So the big limitation was that it was looking at most of the studies that they had included in this RCT, in this meta-analysis, looked at prophylaxis using acetylcholinesterase inhibitors in surgical patients after elective surgery, really very, very minimal medical ICU patients. And the drugs that were used, there were many different drugs, different doses, different protocols that were utilized. The delirium scales that they were looking at also was quite variable as to how they assessed the occurrence of delirium, or the severity of delirium was also different. So as far as generalizability of the study goes, mostly it's applicable to older surgical patients who are undergoing elective surgery with prophylactic anticholinesterase inhibitors, less generalizable to medical ICU patients. The one drug that frequently in this particular meta-analysis looked like it was favorable was transdermal rivastigmine. So what does that mean for us, and what is that implication for our clinical practice? Prophylactic anticholinesterase inhibitors, primarily rivastigmine, may reduce the occurrence of delirium in older patients who are undergoing elective surgery. Really no clear benefit for established delirium, and we don't have anything to say that we have to use it in all hospitalized patients or in all ICU patients. The next study is, again, a very interesting topic in critical care, is gram-negative sepsis and duration of antibiotic therapy. It is a severe, complications occur with gram-negative sepsis. Historically, we've treated it with 14 days of antibiotics. Many studies had shown that, maybe a shorter course of antibiotic might be equally effective in these patient subgroups, and you don't have to do 14 days of antibiotics. So this is a systematic review and a meta-analysis that looked at that. And it combined 4 RCTs, which was looking at 14 days versus 7 days of antibiotics for gram-negative sepsis. So this study had RCT in which the patients were adults who were hospitalized with gram-negative bloodstream infection, randomized to either 7 days or 14 days. And the primary outcome they were looking at is 90-day all-cause mortality. And what they found was that the 90-day mortality, and also they wanted to look at non-inferiority primarily of the 7-day antibiotic therapy as compared to 14-day therapy. And the 90-day mortality in the 7-day group was about 12% and 13.7% in 14 days. So pretty much 7 days was considered to be non-inferior to 14 days. It's a 97.8% probability of non-inferiority. Even in the per protocol analysis that they looked at, 95% probability of non-inferiority. So as far as limitations go, the big ones was that it was only 4 randomized control studies that were taken into this meta-analysis. And this was for uncomplicated patients. So patients who were immunocompromised or who had complicated infections were really not represented in the sample of these 4 RCTs. So as far as generalizability goes, it is mostly applicable to adults who have uncomplicated gram-negative bloodstream infection. And so in stable patients, for us to take away from the study in this meta-analysis is that in stable patients with adequate source control, 7 days of antibiotic therapy is probably going to be sufficient for gram-negative bloodstream infections as compared to 14 days. And a shorter therapy might actually come with its own set of advantages of lesser catheter days, lesser adverse events, and lesser antimicrobial resistance as well. This is a topic that has been controversial in a lot of our ICU rounds about what is the target of blood pressure that we need to have for patients who have septic shock. So we really don't have a concrete evidence on what is the most optimal blood pressure that we have to maintain patients who have septic shock. Generally, about 65 is what we consider. There was a thought that maybe we need to have a higher target for the blood pressure, and that would be associated with better outcomes. But there are multiple studies that have been done which showed that it was really not beneficial to target a higher MAP, except in patients in certain subgroups. Maybe if they had chronic hypertension and their curves were shifted, maybe it's going to be beneficial. So now Japan has a pretty high prevalence of chronic hypertension. It seemed like a great patient subgroup to do this study in. So OPT-PRESS, which is the study, it aimed to assess whether a higher MAP goal would improve outcomes in older patients with septic shock. So again, multi-centric study, 29 Japanese hospitals were included. Adults who were over 65 years who had septic shock were randomized to either a high MAP goal or the normal MAP goal, the standard MAP goal. When they said high, what is actually high MAP is about 80 to 85, versus the standard was like 65 to 70, keep them around 65 to 70, within about 1 hour of initiating a lever-fed norepinephrine infusion. They did protocolize them to receive vasopressin early just so they could minimize the exposure to catecholamines. And the primary and the target MAP that they were aiming to keep those patients in, they wanted to maintain it for about 72 hours or when these vasopressors are discontinued. So the primary outcome that they were looking at was the 90-day all-cause mortality and multiple secondary outcomes, including 28-day mortality, organ support-free days, lactate clearance, and whatnot. The main thing that they saw, that 90-day all-cause mortality was higher in the high MAP group. It was about 39% as opposed to 28%, about a 10.7% difference as an absolute risk. So the high MAP had a higher mortality, as 90-day mortality, as compared to the standard MAP group. Similarly, in the 28-day mortality, and there was really no patient subgroup that they identified that high MAP was beneficial as far as outcomes go. So there were some limitations to this study as well, is that it's open label, there's really no blinding of clinicians. It is hard to know if the chronic hypertension was actually labeled accurately because it was from a diagnosis code, which was there in the chart. So it is difficult to say it was labeled correctly. There was really no standardization of what vasopressors were used, how did they titrate the vasopressors. And it is quite a homogeneous cohort because all of these were Japanese ICUs. So for Southeast Asian populations, it is probably most applicable to older Japanese or similar populations with chronic hypertension and a higher hypertension prevalence. It's harder to extrapolate these findings to different ethnic subgroups and younger patients. So for us, what do we take away from this study for our clinical practice is that high MAP is associated with an increased mortality and worsened organ support outcomes despite early vasopressin. And a standard target of about 65 to 70 millimeters of mercury seems to be helpful, and it is more safer in patients who have septic shock. The next study I'm going to look at is propranolol as an anxiolytic to reduce the sedative use in critically ill patients who are mechanically ventilated. So the study came about because when it had COVID-19 happened and all of the sedation shortages, sedation agent shortages came about, there was a lookout for other things. What other things, other alternative medications could be used to help with sedation protocols that we have in our ICU? So propranolol is a non-selective beta blocker, and it has a central sympatholytic activity, and that could be helpful in reducing sedation requirements in patients. So that was the basis for this proactive trial, it is a randomized controlled trial. It is multi-site and was open label. 3 academic centers in Canada is where this study was done. The inclusion criteria for this was adults who were requiring high-dose propofol. When they said high dose, what does it mean? It is over 1.5 milligrams per kilo per hour, or higher midazolam of greater than 3 milligrams per hour that was required for over 24 hours. And they were expected to have mechanical ventilation or need mechanical ventilation for greater than 48 hours. So the intervention was enteral propranolol, 20 to 60 milligrams, that was given every 6 hours with a propofol titrated sedation. And the control group was just your regular propofol sedation that was used as per protocol in the ICU. The primary outcome that they were looking at was the percentage change in the daily sedative dose from baseline to day 3. And the secondary outcomes, they had multiple outcomes they were looking at, including how long they were able to keep their RAS inside target and how much additional opioid dosage the patients required. What they found was that propranolol significantly reduced the total sedative requirements by day 3 as you compared it with the control. Patients who received propranolol had a greater proportion of time where they stayed within their target RAS. And the patients were weaned to minimum sedative doses by day 3. It was comparable between the groups. The opioid dose changes were not really significant between the propranolol group and the group that did not receive propranolol. Again, this study did have some limitations that it was done in 3 ICUs in Canada, may not reflect cannot be generalized to all the other sedation practices that we have across the world. It was really not centered and powered for patient-centered outcomes. Most of the patients who were there in the study tend to receive propofol. Very few patients were receiving midazolam as their primary agent for sedation. And there were no very sick patients were not included in the study, like patients who are on high-dose vasopressors, patients who required neuromuscular blockade. Those patients were really not included in this group. So as far as generalizability, these findings probably apply to moderately ill patients who are ventilated in an ICU, as far as adult patients go, who are requiring high-dose propofol. And we really need to be cautious as to how we extrapolate this information to other patients who might be sicker or in different systems who are using different other sedation protocols and not just a propofol-guided sedation protocol. So as far as takeaway for us from this is that propranolol significantly reduces the sedative requirements and it improves target sedation attainment. And it could really be a helpful strategy if you have more studies which are more robust, looking at different patient populations and different sedation protocols. It might be a really great way in which we could minimize the sedation drug uses in the ICU. The last study that I'm going to talk about is serious illness conversations in the emergency department in older adults with advanced illnesses. So serious illness conversations are important for us, especially as ICU physicians. And it is really aligned with patients' value. And so we make sure that we're doing the things that the patient really wants and wishes for. But it's difficult to have these conversations in an emergency room, even though older patients tend to have multiple ED visits during their end of life. And that's a really great target for us to have, or an opportunity for us to have these conversations with them. So ED goal is something that they implemented. It's a nurse-led strategy. It's a multimodal intervention that they wanted to implement, and they did implement, to have these serious illness conversations with patients when they show up in the emergency room. It was a randomized clinical trial. 3 Boston EDs is where they did this. And it was adult patients with serious illnesses. Most of them actually had metastatic cancer in these groups. And the intervention was called as ED goal, where the nurse has a motivational interview with the patient or their caregiver who's there, and then they have a structured serious illness conversation to kind of prime the patients into having these conversations about their illness and end-of-life goals and care. And the control was just the usual questions that the nurses ask about, do you have advanced directives? What is your code status, and things like that. So the primary outcome that they were looking at was patient-reported engagement in advanced care planning. So that was the primary goal at 1 month, is what they wanted to look at. And the secondary outcomes was clinician documentation of these conversations. How well did the clinicians document these serious illness conversations in the medical record? Did they complete this at 1 month and in 3 months? Did the patients complete their advanced directives? And the quality of communication. These are the things that were secondary outcomes that were looked at. After this intervention was done, the thing that they saw, their primary outcome, which was the 1 month ACP engagement, the advanced care planning engagement, they did not find a huge difference. But the patient-reported serious illness conversations with the physician at 1 month was significantly higher. So I think it has clinical relevance. I know it was not statistically significant, but it was clinically relevant, 17% when they had the intervention versus 7% when they did not. The clinician documentation of end-of-life values at 3 months, 6 months, and their healthcare proxy completion actually did go up. So it does show us a clinical opportunity there to have these conversations with patients. So no difference in patient-reported ACP engagement, but definitely an increase in clinician documentation of having these serious illness conversations and patients completing their advanced directives and healthcare proxy paperwork. Limitation was that it is a single health system. It is a small sample. There is a selection bias. It really did not measure how good those conversations were, the serious illness conversations that the nurses were having. We really don't know. I guess we do not know if they were quality controlled or not. And the generalizability is probably applicable to large urban EDs with the palliative care sources. We really don't know if we can generalize it to like a rural, smaller setting that does not have all the resources that are required. So for our practice, what does this mean for us? ED visits can really be leveraged to have serious illness conversations for stable but seriously ill patients. And these nurse-led interventions can really help with downstream clinician documentation, and it can really prime the patients to have these conversations if they were to come back to the hospital. I have the QR code here for all the summaries, and this is where I will stop and then give it over to Dr. Flynn.
We may need some tech help.
Let me get somebody.
sorry for this. Oh, there it went. It came up. Oh, just went up there. Okay.
You had to minimize it? So we are done with this
No,
presentation?
that's the one that needs to go.
This is the one that needs to go. Okay, so this is the first original one that we were working with? Or do we need to go back to orchestrate?
It's only on
It's
here.
for that
It's
one.
not on-
Okay. What is it? This one?
Thank you so much. Sorry about that delay. So to finish this off, we have a few more papers. This one is called the Computed Tomography, Perfusion, and Angiography for Death by Neurologic Criteria. So basically using imaging for brain death criteria. The objective of the study was to determine if these CT perfusion and CT angiography studies could be a predictor of brain death or death by neurologic criteria. This was a prospective, multi-center, blinded study in 15 ICUs in Canada. The participants were all adults. You had to have a GCS of 3 to be included in the study. They had 282 patients in the study. Of those 282 with GCS of 3, only 204 were declared brain dead by standardized clinical criteria. So those patients went on to have either CT perfusion or angiography scans. And the validation threshold was quite high. The sensitivity and specificity of the scans had to be above 98% to be considered valid. And none of them met that. None of those scans met that. The CT perfusion brainstem did meet the sensitivity criteria, but was really poor on the specificity criteria. So it probably over-included patients who were not actually brain dead. As you can see, nothing else was significant. So the take-home message of this study was that none of the imaging modalities, and these are very high-tech imaging modalities, met the accuracy threshold of greater than 98% and should be used only as ancillary rather than standalone tests for confirming death by neurologic criteria. So pretty interesting. The next study I'm going to talk about is called A New Global Definition of Acute Respiratory Distress Syndrome. As my colleagues have said, you can't have a critical care talk without ARDS, so here we go. So basically, they wanted to revise the old definition, which was created, it's called the Berlin definition of ARDS, created back in 2012. So they gathered 32 ARDS specialists, and they also got input from the major societies in critical care. They included the use of high-flow nasal oxygen. They wanted to expand the use of pulse oximetry in place of ABG, arterial blood gases. They wanted to include the use of ultrasound in place of other chest imaging. And they also wanted to talk about the need for the applicability in resource-limited settings, such as rural areas or other countries. So the main 4 recommendations and the changes include these. They now include high-flow nasal cannula oxygen at a minimum flow rate of greater than 30 liters per minute. So in case the patient isn't intubated, as we learned in COVID, not all of these really sick ARDS patients actually need to be intubated sometimes. You can now use this definition of high-flow nasal oxygen. Instead of, you can use a PF ratio of less than 300, or if you only have pulse oximetry, you can use a SpO2 to FiO2 ratio of less than 315. To identify hypoxemia. They retain the bilateral opacities on imaging, such as chest X-ray or CT, but also now we can add ultrasound imaging, such as continuous B lines, and actually the presence of consolidations on ultrasound. And in resource-limited settings, they do not require positive and expiratory pressure, because not all ventilators in other countries may measure PEEP, oxygen flow rate, or specific respiratory support devices that need to be in place. So basically broadening the definition of ARDS. This paper, if you can go to it, and the QR code for all our papers is up in the corner, has a really nice table about the old criteria, new criteria, and the rationale. The next paper I'm going to talk about is called Conservative Oxygen Therapy in Mechanically Ventilated Critically Ill Adult Patients, or the UK ROCKS randomized clinical trial. The question they wanted to answer is one that we as intensivists may have debates on rounds all the time. Avery probably says, bring me papers on this side and bring me papers on that side, because this is a great topic. Is there harm caused by too little or too much oxygen in the ICU? So this is a multi-center, pragmatic, randomized controlled trial in 97 ICUs in the UK, included more than 16,000 mechanically ventilated patients. So patients were randomized to either the conservative O2 therapy, where the lowest FiO2 possible was given to maintain a SAT of 90%, or usual oxygen therapy at the discretion of the treating physician. The primary outcome was all-cause mortality at 90 days. Secondary outcomes included ICU and hospital stay, days alive, and free from organ support at 30 days. And just to show you that the arms actually did a fairly decent job of maintaining what they were supposed to do. The top graph there, you can see the supplemental O2 was 29% lower in the conservative arm. So patients actually did get less oxygen if they were in the conservative arm. SpO2, however, was only 2% lower in the conservative arm. The average in the standard of care arm was 94%, and the conservative arm was 92%. So if that 2% makes a difference, we don't know. But the bottom colored graphs show you that 90% of the 90% range was met much more often in the conservative arm than in the standard of care arm. So I think, for what they had to work around, I think they did a good job of maintaining the arms of the trial. However, by 90 days, exactly 35% of participants in each arm had died. So there was no difference in that outcome or any secondary outcomes. The conclusion, the findings do not support an approach of reducing oxygen exposure by targeting a SAT of 90% in mechanically ventilated adults. So the paper battles can continue back and forth about what to do there. The next paper, association between driving pressure and subsequent development of AKI, or acute kidney injury, in adult respiratory distress syndrome. So again, another ARDS paper. The driving pressure is the difference between the plateau pressure and the PEEP. And many studies before this have shown that a driving pressure less than 15 centimeters of water pressure is often targeted, as a higher driving pressure is associated with increased mortality and ventilator-induced lung injury. But less is known about AKI, or kidney injury. So this paper had a design, it was actually a secondary analysis from previous ARDS trials, 7 of them, from the ARDS Network and Prevention and Early Treatment and Acute Lung Injury group, or the PETAL group. So those 7 randomized controlled trials included almost 3,000 patients. This team undertook a secondary analysis from that data. They included patients who developed AKI between 2 and 7 days following their diagnosis of ARDS. And they used the KDIGO Stage 1 criteria for AKI. Outcomes, they found that each 6.6 centimeter water pressure increase in driving pressure was associated with a 35% increase in AKI, and that was significant. They also went on to analyze that among patients with a mean driving pressure greater than 15 or greater, the driving pressure was associated with AKI. So as a binary outcome, greater than 15 was associated with AKI, but less than that, every 6.6 centimeter water pressure increase in driving pressure also caused AKI. The take home is that injurious mechanical ventilation may lead to AKI, and we should take approaches to reduce driving pressure to potentially have protective renal effects. This one looks at video laryngoscopy versus direct laryngoscopy in class 2 and 3 obesity. This was a systematic review, meta-analysis, and trial, sequential analysis of randomized controlled trials. So we know that respiratory complications are overrepresented in patients with class 2 or 3 obesity. They undertook this systematic review of 10 randomized controlled trials, and they basically compared in groups of about equal numbers, 481 and 474, of video laryngoscopy to direct in these patients. The primary outcome was incidence of failed intubation, hypoxemia, and first attempt tracheal intubation, the success of that. Secondary outcomes were glottic visualization, time to intubation, incidence of sore throat, and difficulty of intubation. So is what they found, and this is the graph there on the left side is what favors video laryngoscopy. On the right side is what favors direct laryngoscopy. So in their three outcomes, failed intubation was much more common in the DL group. Hypoxemia, significantly more common in the DL group. First attempt success at intubation, more common in the video laryngoscopy group. So in all of their outcomes, video was superior to direct laryngoscopy in these obese patients. So patients living with class 2 or 3 obesity are likely to benefit from video laryngoscopy compared with DL. And this last paper, switching from pulmonary to cardiac, this one just came out, so it's pretty interesting. It's called the DIGIT HF, or Heart Failure Study Group. Digitoxin in patients with heart failure and reduced ejection fraction. So just because we, most of us practice in the United States, digitoxin and digoxin, which we use here, are both cardiac glycosides with similar effects on the heart, but they do differ significantly in their half-life. Digitoxin is 5 to 8 days, digoxin 1 to 2 days. The body eliminates them differently, hepatic versus renal, and they also bind to proteins differently. Digitoxin is more lipophilic, digoxin is more hydrophilic. So knowing those differences, they both strengthen heart muscle contractions and slow heart rate. There is a lot more evidence for digoxin that we use in the United States, although they are presumed to be similarly effective, but I do want you to take that with a grain of salt. This paper is only on digitoxin because it was a European study. So this had included 65 sites in Austria, Germany, and Serbia. It was double-blinded, placebo-controlled trial with 1,212 patients. They only included patients with heart failure, EF less than 40, or NYHA class of 3 and 4, or you could have an EF less than 30 with an NYHA class of 2. The primary outcome was death from any cause or hospital admission for worsening heart failure with a median follow-up of 36 months. So the primary outcome, which again was either death or any hospital readmission for heart failure, occurred in 39% of the digitoxin group and 44% of the placebo. So that's that top graph. So that was statistically significant, showing that digitoxin was perhaps superior. However, when you break down the primary outcomes, death was not different in the two groups. Readmissions for heart failure were not different in the two groups. So there's lies, damn lies, and then there's statistics, right? And just of note, there was at least one serious adverse event in 4.7% of the digitoxin group and only 2.8% of the placebo group. And they never tell you what these adverse events are. They just say they're cardiac disorders, and you have to go to the supplemental data to even see if that was significant and what those were. So, take that with a grain of salt. The take-home message was that treatment, by the authors, not mine, is that the treatment with digitoxin led to a lower combined risk of death from any cause or hospital admission for worsening heart failure than placebo among patients who had heart failure and reduced ejection fraction, who also were receiving guideline-directed medical therapy. They say the number needed to treat with digitoxin is 22 to prevent one primary event. So this will be a great journal club paper, and we'll see if we replicate this in the United States with digoxin, which is the drug that we use. Please scan this for a summary of the papers, and thank you all for being here, and I'm sure we can take some questions. If anyone has questions, please raise your hand or step to a microphone, or comments are appreciated.
We have about 5 minutes
Yeah.
for any questions. Otherwise, we can all escape out of here with 5 minutes left on our session.
Great job, thank you.
Thank you.
Thank you.
Happy birthday, Dr.
We are on.
It's okay. Please go ahead.
This is for Dr. Sridharan, my former program director. For the propranolol study, I noticed that we mentioned that was going to be helpful with our sedation, but did they ever look at patients who had primary neurological injury or needed rapid neurological assessment if it was appropriate to use in that subgroup of patients?
I don't believe they had this kind of subgroup analysis on that one. No.
Oh, that's a bummer.
Yeah.
No, because I don't know, like whenever you have one of those hypertensive bleeds who end up in the ICU with severe hypertension, but difficult to get them to sync with the vent, it sounds like a very good idea.
Yeah.
But then what do you do when you need to do a rapid neurological assessment if there's like leftover sedative effect from the propranolol?
It's a good point. And I don't believe they looked at that specifically in this particular paper.
Oh, well.
Yeah. Thanks, Ian.
Great. So I have kind of a comment and a question for Dr. Flynn. Whenever I read a consensus statement about anything, what it means is there's no consensus, right? The second thing about consensus statements that's absolutely true is they follow practice and study design rather than lead it. So now that people have studied, and published on the ratio FiO2 to saturation, right? Oh, well, we've got to resign the consensus guidelines to include that as well, right? So do you really think there's going to be a lot of uptake of this, or do you think this is going to be the next failed consensus statement for the design of clinical trials of ARDS?
What do you think?
I think it's doomed. I think it's really helpful, right, to kind of acknowledge it so that people don't fight with insurance companies that, like, this person had ARDS, but we gave them high-flow nasal cannula, right? Mm-hmm. But the idea that, like, people are going to say, and we strictly adhered to this definition, there's going to be zero of that.
Yeah. I do think from reading it, the intentions were good. The people that can't do A-lines, like you, can still have ARDS. But yeah, I agree with you.
But, it's funny because, I mean, this is a characteristic of consensus statements, but we still need them.
Yes. Thank you, Dr. O'Connor.
One more question about the AKI and driving pressures. So most of the patients who die from ARDS die from multi-organ failure anyways, right? Mm-hmm. So is it that the higher driving pressures or the issues with ventilation may actually just be associated with those patients are just sicker and are going to pass away anyways? Because that was the thought that I was having as I was listening to that presentation.
100%. And that's why I wanted to give a little hint that the AKI definition was KDIGO class 1, which is, 0.3 creatinine increase, which anybody in the ICU, if they're sick enough, is going to have. So I 100% agree with you. I appreciate you saying that statement. I didn't want to add too much commentary, but what you said is exactly what I was thinking too.
Just an association.
Thank you very much.
Thank you.